Hello and welcome to #OurDocTalk. This is NorthBay Healthcare's outreach to our community on issues of importance to our health. With us today is Dr. Milind Dhond. He is a cardiologist with NorthBay Healthcare. He's a graduate of the University of London. He did his residency at the University of Pittsburgh, a cardiology fellowship at UC Davis, and is a professor at UC Davis. He's the director of cardiology for NorthBay. Thank you for taking time out today to do this. Let's just get started right away. We're in February, which is Heart Health Month. And my first question has to do with Heart Health Month. Why is this such a big deal in the United States that we have a whole month dedicated to heart health?
Well, if you look at heart disease, this is not just limited to the United States, but if you look at it globally, it's one of the leading causes of death worldwide. In fact, in America, it's the leading cause of death. And if you look at the number of people that die, 1 in 3 people will die from cardiovascular disease in America. And just to give you a perspective, you have all this publicity about, lung cancer or breast cancer. If you were to take all the forms of cancer combined and all the forms of lung disease combined, there's still more people dying from heart disease than all of those things combined. The death rate from cancer is from heart disease has declined over the last few years by interventions, but still remains very, very high. So if you think about it, 1 in 3 people, you've got a pretty good chance that you're going to have heart trouble, just statistically.
And so why is that? Is that unique to the United States? Are there other countries that face the same problem?
No, actually other countries have the same problem. Part of that may be because they're adopting the US diet, but in general, if you look across the board in Europe, statistics are fairly similar. And then as people eat a westernized diet in other countries, then they tend to get cardiovascular disease, which kind of goes to show that there's a huge link between diet and the prevalence of cardiovascular disease. If you look at it, I think if I've got the stats here on the worldwide. If you look at it in America, there's probably 2,300 deaths every day. If you look at worldwide, there's still a huge proportion. It's still globally, it's the leading cause of death as well. So there's 18 million people die from heart attacks in the world every year. And in America, it's still pretty high. There's probably 2,300 deaths every day in America from heart disease. So I think primarily if you look at third world countries, they have less incidence of heart disease. If you look at countries like India, they have a much higher incidence, and that's because a lot of the food there is cooked with oils. But if you look at third world countries, their incidence is lower.
And so what's causing this? What are we doing wrong as Americans that maybe healthier countries aren't doing?
Well, you could, just sit in a mall for 10 minutes and have a look. So there's people that, in general, if you look, people... There's things that you can inherit. So you could inherit high cholesterol, or you could inherit parents that both died when they were 40 from a heart attack. But there's things or you can inherit diabetes. But there's things you can change yourself. So you could exercise regularly, which reduces your incidence of cardiovascular disease. You could eat a healthier diet, which would keep your cholesterol low. If you had a diet low in fats, and you could have a low cholesterol. If you had a diet low in salt, your blood pressure would be lower. If you exercise, those profiles would be better as well, which means your blood pressure would be lower, your cholesterol would be lower.
So
you could not smoke cigarettes as well.
Smoking is one of the big no-nos.
Right.
When we're talking about heart health.
Yeah, and if you look at statistics for smoking, the stats for smoking have gone down hugely over the years, but probably 15% of the population currently still smokes. It's probably like 1 in 7, 1 in 8 people. So that's still quite a huge number of people. If you look, it's lower in young adolescents. So adolescents from the age of 12, 17, it's about 6%, and The average age of starting cigarettes is about 18. So if you can not have your kids smoke until at 18, then the likelihood of them starting is much lower.
Yeah. So explain to us what's happening in the heart when you say a heart attack. What is that? What's going on in the heart?
So patients often confuse the terms heart attack and stroke. So a heart attack, a full-blown heart attack usually means that the arteries that supply blood to the heart, there's three main arteries that do that. It indicates a heart attack is where you suddenly block one of the arteries to the heart with a blood clot. And usually what happens there is you already have some buildup in the arteries, which is typically called plaque. And the plaque, comes from cholesterol, diet, diabetes, if you smoke. And you rupture the plaque, and then what happens is a blood clot forms around that and blocks off the artery. That typically will present with very severe substernal chest pain, or it can present with severe arm pain or sudden onset of shortness of breath. If you're unlucky, a third of the people will just die suddenly from that as soon as it occurs. And that's typically because if you damage a portion of your heart is a very electrical organ. So if you damage a portion of that, you can get electrical disturbances where your heart will stop suddenly. So a third of people have a sudden cardiac arrest and die suddenly from their heart attack. So there's different types of heart attacks. So you could have so that's a full-blown heart attack, and typically that's obvious what's happening. You will get brought by an ambulance to the hospital. There'll be obvious changes on your electrocardiogram. And the current recommendation is that you get taken directly to a heart catheterization lab, and there are various designated centres, like the ambulances that pick you up know where to take you if that's occurring. NorthBay is actually one of those centres. And a team will be called in as soon as they make the diagnosis. And the idea is to try and take a catheter up into your heart and put a balloon through the clot and balloon it open so the artery is open again. And then typically you would get a stent, which is like a metal mesh that holds the artery open. You get that stented. So that's the typical treatment for a full-blown heart attack. If you can get that done within an hour, then you really limit the amount of damage to the heart, which is the main problem going forward from a heart attack, is that you get a scar.
And you can't repair a damaged heart.
Not currently, no. You typically get put on medicines that try and limit the amount of damage once you've had the heart attack. But once you've got the scar there, you've got the scar, and there's no getting away from that. If you have a very big scar, that means you're going to be prone to getting congestive heart failure down the road. You could have a different type of heart attack where you get some clot building up in the artery and your body dissolves a bit of it, and then it reforms and dissolves, so you can get this stuttering chest pain that occurs. And when you look at somebody's electrocardiogram or EKG, it doesn't have the typical findings. And so those kind of patients, although they have a heart attack, we tend to bring them into the hospital and put them on heparin, which we call it a blood thinner. It doesn't really thin out your blood, but it just makes it less likely to clot. And often the clot will dissolve, and then you can wait a day or two before doing an angiogram. So
you started out by saying that a heart attack is different from a stroke.
Right, so a stroke is the patient will say, I had a heart attack or a stroke or whichever. So a stroke is where you get a blood clot in one of the arteries to your brain. So it's a totally different subset of conditions because it's a neurologic condition involving your brain. And typically the presentation there will be you lose either vision in your eye, or half of your body will lose power or sensation, or you may pass out and wake up with these things. It's similar to cardiac heart disease in the sense that it's got basically the same risk factors. So you're more likely to have a stroke if your blood pressure is too high, if your cholesterol's high, if you smoke cigarettes. The same principle holds true there, that the quicker you can, if you're having a very big stroke, the quicker you can get that artery open, the more brain tissue will be saved, and the more likely you would be to have a full recovery. The way of getting the artery to your brain open is by using a drug called a thrombolytic, which is injected into your body, and it dissolves all the blood clots in your body. So it will dissolve the blood clot in most cases that's in the artery that's going to the bit of your brain that's blocked.
Can you explain what's the difference between angina and a heart attack?
Yeah, so as we just discussed, a heart attack is where you have a sudden blockage in your artery going to your heart, and it gives you severe chest pain. You go to the hospital, you get an angioplasty, the pain goes away. It usually is where you have a plaque. The way of describing that is, if you have water, you have your pipes that supply water to your house, and you get lime scale building up. So that's the best analogy. So what angina is if you build up the lime scale in your arteries, or say the plaque becomes gradually more and more, you are not going to have enough blood flowing to your heart, particularly when you're doing physical activity. So the presentation for that would be you would start getting a pressure sensation in your chest, or it could be in your jaw or in your arms. It's typically going to be when you're doing physical activity. So a typical patient description of that would be, when I walk up the hill to the post office, I get this pressure in my chest, and it becomes moderately severe, and then it resolves when I stop. So that would be a classic textbook definition of angina. So angina is indicative of a blockage in one of the arteries to your heart that's moderately tight. There's different types of angina, so that what I just described about walking to the post office would be exertional angina. If it comes on every time at a certain distance, that would be considered stable angina, but stable exertional angina. Sometimes you'll get patients that the blockage is very tight and they're intermittently having such poor blood flow that they will get worse. The angina will start worsening and the distance will become shorter and shorter. So it might be somebody, and that would be considered unstable angina, or sometimes called crescendo angina. And that's where they'll say, well, last week I was walking 100 yards and getting tightness, and then 3 days ago it's 50 yards, and now it's 10 yards. Mm-hmm. And sometimes you'll get that at rest. And typically unstable angina, you need to get admitted to the hospital for that, because that needs, like we said, it needs various different medications that take pressure off your heart.
And it can be a precursor to having
it can be, yeah. I mean, you know how everybody's different, so some people will just wait and wait and wait until it reaches a crescendo like that, and then other people will get seen beforehand. So if you get seen beforehand, you can get that treated, and if you don't, then you'll just have to rely on the luck of the draw to see what happens.
And hope for the best.
Yes.
Well, how does somebody tell if they're having heartburn or a heart attack?
That's a very difficult. It requires a series of different types of tests and different types of evaluation. So the best way of actually diagnosing it is the story, which means if you ask the patient specific questions, you can often get an idea of whether that's truly heartburn or truly angina. Mm. So a good one for heartburn would be, it occurs every time, 30 minutes after I eat food. I get a bit of acid, I burp, and then I get reflux. And if you said to that patient, well, whenever you exert yourself, do you get that symptom? And if they said, well, I go cycling 2 miles a day and I never get that symptom, then that makes it less likely it's angina and more likely it's GERD. And, vice versa, which means if the symptom, because we will often see people with reflux and heartburn, and it'll be angina because they'll say, well, I get reflux every time I walk up the hill to the post office. My heart, my reflux comes on, and I'm like, but is that just when you're exerting yourself? And they'll be like, yes. So to me, that would be angina and not GERD. Because the risk of heart disease is so huge, if somebody comes and even if they have symptoms of GERD, we'll still try and screen them with a stress test. We won't just say, well, don't worry about it, it's just GERD. And the reason for that is because you can do relatively cheap testing of patients. So you can just put a patient on a treadmill, something called a stress echo, where you ultrasound their heart, put them on a treadmill, and then ultrasound their heart at peak exercise. And that's a very safe and easy screening test. And I don't think anyone's ever said to me in my whole career, thanks for not checking that out.
Right.
So if somebody comes in with, and it sounds more like GERD, if they have a few risk factors, I still say, well, you should just go on a treadmill. There's nothing to be lost from it. And if you miss these things, everything could be lost. So.
Right. So I've heard you say before, prevention is better than treatment. What can we do to prevent it?
Yeah, so preventing heart disease comes back to various, different aspects of the thing, which means you can have genetic predisposition to coronary disease. So in that case, if the genetic predispositions are typically very high cholesterol, or if you're prone to getting diabetes, so then if you're one of those people, you need to treat those things. And then that may sound obvious, but there's also people with very high cholesterol who are like, no, I'm just going to do a diet. And they do their diet and their cholesterol is still very high. And then they're like, well, I'll see how I go. And I always tell them, look, you're just conning yourself. Right? Your cholesterol is super high. Your dad died when he was 40 from a heart attack. Unless you change that, that's going to be you. So then those patients, I say, well, you put them on these various medicines that block cholesterol production. And typically they're termed statins, and there's probably about 7 or 8 on the market. They're relatively safe, but a few of them, there's occasional side effects you can get. So when you start these medicines, you need to monitor liver function and various other things. If you're diabetic, you need to make sure your blood sugar is under control, that you check your sugars yourself. If you don't have those things, and then the other thing is high blood pressure. So if you have high blood pressure, you want to make sure you stay on a low salt diet. If your blood pressure is typically too high, then you should go on medications. In general, you want to try and have a thing where you have an exercise plan that's just part of your routine. It's not something you should never view it as an extra. It's like, do you go to the supermarket to buy food? Well, that's how your exercise should be. And then similarly, I'm not a great believer in people doing diets, which means a diet, if you're overweight and you're on a diet, that's fine. But at some point, if you view your diet as a temporary thing, your diet is going to end and you're going to go back to eating the way you were eating, and 6 months later you'll be back to the same weight. So I typically tell patients that you should just adjust the way you eat regularly and just drop things that have a high calorie load and see if you can lose weight that way. But
we have someone asking about the efficacy of niacin in reducing triglycerides and cholesterol.
Yeah, so niacin is so this is one of the things in medicine. So niacin is an agent that's been around for probably 50 years. And when not that I've been practicing medicine for 50 years, but 30 years ago when I was...
You don't look old enough to have been practicing medicine for 50 years.
But 30 years ago I was in medical school. So niacin, and that was kind of before statins came out. So niacin is one of these agents that comes in and out of vogue every few years. So what that means is, and I don't want to worry people, but medicine is not fixed science. But that's fairly self-evident, which means...
Is that why they call it practicing?
Yes, exactly. So niacin has been used to raise the good cholesterol, which is HDL, and also to reduce triglycerides. And many years ago, before statins were there, people would just give it to anyone with high cholesterol. So then it went through a phase where people were using it regularly for trying to raise the HDL, which is your good cholesterol, and also to reduce triglycerides. And then in the last few years, there have been several studies that show that it has quite a lot of side effects. It gives you a lot of flushing, and there's a few studies that demonstrated that it wasn't that effective at doing these things and didn't reduce your overall risk. So the current trend, and this may change, like I said, but the current trend would be not to use that much niacin. So the amount of niacin being used today is much less for triglycerides and for bringing up your HDL, and there's other agents such as fibrates, and even things such as fish oil will do a similar effect. But that's the current state. In 2 years' time, somebody's going to publish a paper showing that niacin is fantastic, and then we'll be prescribing it again. But
so we talked about how you can't reverse damage once it's done to the heart, but what about things like the buildup of cholesterol? Can you actually reverse the buildup of cholesterol, or once it's in there? Plaque.
Yes, plaque.
Once it's in there,
so you could. So there's two ways of saying, well, if you say you had a 50% blockage in your artery from plaque, there's a couple of ways you could say, how would you get that out? You could say, well, if you went on a cholesterol blocker like the statins and you took a very high dose and you made your cholesterol very, very low, would that plaque eventually get dissolved? And the answer to that is probably not, which means studies show that if you really reduce your cholesterol to a huge level on these medications, the plaque may shrink by 1 or 2%. So to me, if your artery is 3 millimeters wide and your plaque is 0.1 millimeter, shrinking that by 1% is not clinically significant. What does happen though is that your risk of that plaque rupturing drops significantly. The other way of getting rid of it, so there's currently no medicines that will dissolve the plaque. There was a study maybe 10 years ago where there was an infusion that seemed to reduce plaque buildup, but then that study never panned out. The patients, for some reason, died suddenly when they were given the infusion. So that's obviously a problem.
Not a good treatment.
Yeah. So, and then the other way would be to try and remove the plaque. So there's different instruments you can use for removing plaque in arteries, and these are not just arteries in your heart, but in your legs or in your neck or various other organs. You know how we're using the pipe as an analogy with the lime scale. So you can do something that's similar to a rotor-rooter, where you can rotate something that can cut the plaque and suck it out. So that's called an atherectomy. You can put a balloon in the plaque and squash the plaque against the wall. Usually it's soft. It's a soft lipid material. And then if you put a stent inside, these stents are covered with a drug that stops regrowth inside the stent. So you could stent it, and then the plaque would be unlikely to regrow within the stent. So those are the current ways of getting rid of it, which means you can rotor it out. Typically, if you rotor it out, you have to stent it, because if you rotor it out and you just left it, you would get this inflammatory reaction that would create another blockage at that same site.
Okay. Are women more susceptible or men more susceptible, or does that have anything to do with heart?
Well, I think if you look at the relative incidence, there's a very high incidence of women having coronary artery disease. If you look at, I'll just give you the statistics for women. So the average heart attack for a woman is 72 years of age. For a man, it's about 65. So women do have very similar incidences for heart attacks, but tend to present a little later. They also tend to present with very slightly different symptoms. And when people looked at it, because the symptoms were slightly different, they tended to get less angioplasty and catheterization, and there was a little bias there against women, not overt, but just because of the slightly difference in presentation. But women are just as prone to getting coronary disease as men, and the incidence is rising significantly in women. And I think they get it on average 7 to 10 years later, and that's primarily because premenopausal women are less likely to get it.
Hormones?
Yes, exactly. Yes. And actually, interestingly, it's probably a hormonal thing. But when men were given in some study were given female hormones to see if it made a difference, and it didn't. So
interesting. We're different creatures, I guess.
Yes,
That's just
exactly.
the way it goes. If there's one piece of advice that you can give to people who are concerned about their heart health, what would you tell them? What's the one thing they should do?
I think it all depends on the person, which means if your parents live till they're 100 and you run 5 miles a day and you know your cholesterol's low and your blood pressure's low, then you're good. If you have risk factors, which means if your blood pressure's high, if your cholesterol's high, you're diabetic, you should make sure you're on top of those things and get screened and do regular stuff like exercise. If you don't know what those things are, you should get them checked out. Because you could get all that checked out in one doctor's visit. You would go there, they would measure your blood pressure, you could have a lab that would screen your sugar and your cholesterol. And that would cover almost all your risk factors just on that one visit. Yeah. And I always say to people, not knowing doesn't reduce your risk. Right. It just means you're conning yourself.
Right. One last question. I know someone who periodically has a heartbeat that skips. Mm-hmm. It freaks him out every time it happens. Mm-hmm. So I'm curious, is that a symptom of anything? Or? Yeah,
so your heart is an electrical organ. It has its own little electrical pacemaker at the top. And that fires a current that runs through your heart on a circuit. And your heart has a design that if that circuit was interrupted, each cell in your heart can fire a current. That's a fail-safe. That's good. The minus of that is every so often, one of those cells will fire in between your regular beats. And then what happens there is that's called an extra beat. And you typically get a little pause, your heart does a little reset and you get a little pause after it. So you feel it as an extra beat. And then you feel as if you skipped a beat. But what you're actually having is a pause. And then because in that pause, your heart's filling with all this blood, then you get a very big beat after that. And it gives you, I always describe it as a feeling of not well-being. So those patients typically show up because they feel like something's not right. And that, if you have a few of those, that's normal. If you're having, 5 a minute or 3 a minute all the time, you should get seen, because sometimes that's a marker that there's something wrong with the muscle itself.
Okay. And when they check that out, they'll put a monitor on you for a while?
Yeah, so typically you would, if we saw somebody with extra beats, they're typically called premature ventricular contractions, or PVCs. So we would put a monitor on them for 24 hours. We'd probably do an ultrasound of their heart just to make sure that there is no structural problem with the heart. So if the monitor, if in a day you have about 100,000 beats, if you had, 500 extra beats, that's nothing. So you wouldn't do anything, and if your heart was structurally normal, you wouldn't do anything. If you're having 20,000 extra beats, you may be put on some medication for that.
All right, so thank you. We're about out of time here. Just a reminder to everybody that this post will stay on the NorthBay Healthcare Facebook page at facebook.com/NorthBay Healthcare. And thank you, Dr. Dhond. Appreciate it.
All right.
Have a healthy heart, everyone.
Yeah, thanks.